Okay, we're live. All right.
Okay.
All right, I'm Liz. I'm Mallory.
Melissa.
All right.
Okay, I'll go ahead and get us kicked off, I guess, here. Um, we are doing a PowerPoint, we are Team Synergy, getting ready to do a presentation over alarm fatigue. And what is alarm fatigue? It is the desensitization of a clinician to an alarm stimulus that results from a sensory overload causing the response of an alarm to be delayed or missed. There have actually been several case studies in regards to alarm fatigue. I'm just going to briefly go over one real quick. The reason this one caught my eye or attention is it was actually here in Des Moines, Iowa, that a veteran died as the result of alarm fatigue. This was a 65-year-old gentleman who was an Army veteran who was taken to the Central Iowa Healthcare System, which is the VA Des Moines. His nurse in the telemetry unit actually shut the alarms off. And the case study, word for word, goes through a registered nurse in the hospital telemetry unit where the patients are kept for continuous monitoring, was subsequently fired for having turned off an array of alarms that were hooked up to all the patients in that unit. An internal investigation showed Nesbitt had turned off the alarms, one of which designed to alert nurses to any drop in the patient's blood oxygen level. We found the patient unresponsive, ashen, pale, cyanotic, and unresponsive. They checked for a pulse, and as we began calling out to the RNs requesting a code blue be called. He said that he later checked on the patient's monitors, and it appeared that all of the alarms in the unit had been shut off for roughly 3 hours. During that time, the patient's blood oxygen level dropped slowly from a normal level in the 90s to the 30s, which is a dangerously low level, for 45 minutes before he realized what had happened. The next slide was just several more case studies. Statistics for alarm fatigue. From 2005 to 2008, the United States Food and Drug Administration, the FDA, Manufacturer and User Facility Device Experience Database, received 566 reports of patient deaths related to monitoring device alarms. A 4-month review of the database between March 1st in 2010 to June 30th of 2010 revealed 73 alarm-related deaths, with 33 attributed to psychological monitors. In a 3.5-year period ending June 2012, 98 serious alarm-related events were reported to the Joint Commission. The events, which happened in all healthcare settings, included 80 that ended up in the patient's death. In 13 other cases, patients lost physical or mental function as a result of delayed staff response to the alarms. Then we go into what causes alarm fatigue. Alarm fatigue occurs when nurses become overwhelmed by the sheer number of alarm signals, which can result in alarm desensitization, and in turn can lead to missed alarms or a delayed response to alarms. The desensitization to alarms occurs largely because the device have cried wolf too often, as the as the fable did. Studies have shown that in some hospital units, more than 85% of the alarms that are sounded are false. The large number of false alarms has caused nurses to turn down the volume of the audible alarm signals, adjust the alarm settings outside the limits, or ignore the alarm altogether, and even deactivate the alarms, which has resulted in sentinel events and patient deaths. How can we prevent alarm fatigue? And I'm going to the best way to prevent alarm fatigue is through proactive alarm management. Inquire whether you have the ability or authority to adjust alarms, where it comes in with patient or actually nurse education, and know your patient's normal vital signs, know where the alarm limit should be set. If you don't have the education or the knowledge to be working with them, you shouldn't be the one adjusting the alarms. Tailor alarm parameters to the individual patient and specific patient population, and evaluate whether they're audible or visual alarms. Critical alarm sounds, and that's just becoming familiar with knowing what alarms go off in your unit and what they sound like. That way when you have an actual critical alarm go off, you're not ignoring it. Decrease the false positive alarms. Degrade the clinician's ability to decipher priority alarms. As a nurse, do we have the authority to decipher whether or not that alarm takes precedence or not, or ignore it? I don't think we do. I think every alarm that sounded we should actually be responding to. Ensure proper skin preparation technique before placing ECG electrodes. Troubleshoot false alarms when they occur. Avoid ignoring them and avoid alarm workarounds. And do not overuse psychological monitoring and avoid keeping the patient on telemetry monitoring longer than necessary, which is a lot of times the case. We have a lot of individuals in the hospital that are receiving cardiac monitoring who aren't even cardiac patients. It's more of the nurses not wanting to actually go in and do vital signs. We just put them on the cardiac monitor, sit at the desk, and then monitor the patient. So if they're actually not a patient that needs cardiac monitoring, don't use cardiac monitoring. Make sure you're using it for appropriate patients so we don't ignore the alarms that are going off. And consider the American Heart Association, American College of Cardiology's evidence-based practice standards for electrocardiographic monitoring in hospital setting. Never turn an alarm off. Consider silencing while you troubleshoot and assess the reason for the alarm and intervene whenever an alarm sounds to make sure that it's appropriate. And now we're going to go ahead and each one of us is going to go ahead and discuss personal experiences with alarm fatigue.
All right, I'll go ahead now, I guess. Okay, so I am a nurse assistant, and I work for Mercy on a med-surg floor. We do lots of orthopedic surgeries. Some of the types of alarms that we see most commonly are going to be the IV pole, the vitals machines that we use, bed alarms. We have a system that transports things throughout the building, and whenever we receive something, that also makes noise. There's more than that, but I can't think of them right now. So there are differences between the types of sounds and the visual aids that we see when these alarms are going off when they're out of their normal ranges. And that was one of actually the harder things to get to know when you start working on the floor and becoming comfortable with it, because at first you want to react to everything. After a little while, you start to realize that the things like the bed alarm are usually, for our floor, the most important. We get patients on the bed alarm because they are altered mental status usually, and they'll be trying to get up and wander when they shouldn't be getting out of bed without assistance. And so when we hear that go off, that's an alarm that we're highly reactive to. We usually are running toward that room, because if they even take one or two steps, they could fall, they could injure themselves, or usually high fall risk. Some of the alarms we are less reactive to are like within the building's mail system, where we transport things, small items we transport. The difficulty there is that the bed alarm and that alarm sound exactly the same. The only difference is the volume. So trying to differentiate that is always a problem, and sometimes you don't react right away to the bed alarms because you think, oh, we just got something up from the pharmacy, that's all, when really, no, it's actually the bed alarm. It's just quieter because it's down the hall. I guess call lights was the other thing I mentioned. Forgot to mention, there are always call lights going off. It's hard to tell which ones are for the bathroom versus somebody just wants a glass of water or ice or a snack, Yeah, I guess that's a good summary of my experience with them. There was one thing I wanted to mention, that I floated down to a different floor the other day, and it was a telemetry floor, which is similar to our case study with the VA hospital and their telemetry floor where their patients are all on cardiac monitoring. And something I noticed that was actually a little scary for me because it was not something I'm used to. On my floor, we never shut off an alarm, ever. You know, sometimes we will, we'll always prioritize one sound versus another sound, but I went down to this floor and they actually had a set of alarms shut off. And I asked the nurse, I was like, okay, so is this normal? Because I can tell that everything's going off, and that's why, the volume would have been annoying. But I was asking the nurse, okay, well, everything's turned off. And she said that that was something they did normally and regularly, which I feel probably needs investigated into. um, Especially on a telemetry floor. I feel that's dangerous. And also, it's not always a good thing having different types of alarms where you feel like one trumps another. Those situations where you have to prioritize, because if you do have one faulty alarm or you're listening for something specifically, you can end up with errors that way. So I feel that since they thought that, oh, my patients are all on telemetry boxes, we don't need to have the vitals machine turned on, I feel that that's highly unreliable. Leads fall off all the time. you know, Things happen all the time where you won't get an accurate read on one thing and then you will on another. That's also something that contributes to all the false alarms going off. But yep, I'll hand it over now.
Okay. I also work on a medical surgery floor, so I know of all these pumps. I know you mentioned IV, vitals, bed alarms, and like the system. We also have SCD pumps that are compression devices with legs that
Yep.
go off and get disconnected. We have PCAs going off that are pain pumps that you can silence those, but if the patient is out of pain meds, the nurse needs to refill their syringes. We have chair alarms that go off. We have pulse oximetry that goes off, and you mentioned call lights as well. Like, all of these go off a million times a day. And so when you look at it for nurses and how they're expected to answer every one of these call lights all the time, you understand why people start silencing things and start doing things that they're not supposed to. Our bed alarms are so sensitive that if a family member goes to sit next to, their mom or dad on the bed alarm goes off. Or we have nurses that sometimes overuse the bed alarm, so the alarms go off for patients who are up with, standby assistance at the worst, that are getting up on their own most of the time, and they have these alarms going off because overnight the nurse thought they needed to have a bed alarm. So alarm fatigue is not just happening, it happens because there are so many beeping things all the time that are being, I think, overused, that people start doing mistakes, like you were mentioning, like the telemetry, that they start turning off things that are critical, and you just get used to things not being critical. Like 90% of the call lights that go off in a day are not critical for nurses, and that's a problem with the alarm fatigue. Is that why are we having all these beeping things that are not something that needs to be looked at right away? Because if you take those away and the nurses are getting less call lights, it would be something that they would come to in a hurry, and that they would be ready and know that this is an emergency, or this is something that I need to be there for. I know that on my floor, in every one of our meetings, we have to be reminded that if a bed alarm goes off, people have to go to it, because we're having nurses that would just sit at the desk and listen to bed alarms go off and just assume that, oh, somebody's in the room, so it doesn't matter, I don't need to go there. And we would have patients fall. And we have surgeries on our floor, so we'd have like hip patients confused getting out of bed and breaking their other hips. So it becomes a problem because people learn that it's not a big deal, and then when it is a big deal, the hospitals and other places are getting, the smackdown because they should be there. We should be there for the alarms and not look at them as just, that's another accident, because 90% of the time they're accidents. So that, for me, as a tech, has shown me a lot. And worries me as a nurse going into that, thinking about what we're going to have to deal with so many alarms all the time. So that was my personal experience with that.
I guess my turn. um, My personal experience, I have actually been in EMS for 10 years. I've been a paramedic for the last 8. I have actually had the privilege of doing pre-hospital patient care and emergency department patient care, being a paramedic in the emergency department. A lot of the patients that we have come in, regardless of what their chief complaint is at the check-in desk, they're immediately, I mean, the initial assessment is get their vitals. And a lot of times, staff to patient ratio, a lot of the nurses or paramedics find themselves limited with the amount of time that we actually have to spend with a particular patient. So when they're coming in, we hook them up to everything and get a quick set of vitals. So we get the pulse oximetry on them, we get the blood pressure monitor on them, and we take their initial set of vitals, and the equipment is left on the patient for continuous monitoring, even though it may not be a cardiac patient. So then we have alarms going off for a patient that may be in for a stub toe. So then when you hear the alarms going off and you set it aside, you don't respond. Or a lot of times we have patients come in that do require constant cardiac monitoring or pulse oximetry, and they're on the cardiac monitor, the pulse oximeter, and the patient either takes them off or they fall off and the alarms are going off, and this happens repeatedly where they roll over, the pulse oximeter falls off, they don't realize that the alarm goes off. We go in multiple times and check on it. After about the 5th or 6th time, he probably just rolled over again. And so then we're a little delayed in responding to that pulse oximetry alarm, and you know, that could have been the one time where the patient truly needed interventions. So tuning those out when we shouldn't be. So one, it is, I guess, it's education all around to the alarms. As far as advising your staff, use the monitoring appropriately for your patients. Don't put unnecessary monitors on a patient. When they come in with a chief complaint, make sure you're addressing the chief complaint and you're utilizing the proper equipment. So if you have somebody come in that's not having respiratory problems or cardiac problems, try to alleviate a lot of the monitoring that we're doing on that specific patient so that we're not getting alarm fatigue. Make sure that that equipment is being used on the proper patients. So then when an alarm does sound, we know it's on a patient that may need our interventions. And it's also educating your patients. If you've started an IV and they're on an IV pump and it's in a location that if they move, bend, whatever, it's going to become occluded and it's going to sound the IV pump off. You know, just a little bit of patient education, you know, hey, you know, if you don't mind, we may immobilize your arm to prevent the alarm from going off, or an occlusion, whatever. Or whatever it is, you know, we're going to be placing EKG patches on you. You know, I know it's uncomfortable, but try to limit the amount of movement so that maybe the patches won't fall off. Or a lot of it comes down to also educating your patients the importance of having these particular devices or monitors on them. A lot of patients, when they see the pulse oximetry on them, they don't realize the significance of having it on, so they take it off and assume everything's going to be fine. So a lot of that comes down to both nurse education and patient education, so that they understand the risks involved for taking it off or getting up and walking around, that they understand the risks and what it does to the staff as well. That, you know, we have multiple alarms going off, we're going to try to prevent the alarm from sounding if it's unnecessary. So we're going to take a little bit of our time to educate the patient to try and eliminate some of those alarms. So it comes down to a lot of the responsibility of the hospital making sure that everyone has the appropriate education. Okay.
As far as how communication is going to help us here, I think that you mentioned patient education, and I think that communicating with your patients, like this class is teaching us how to effectively talk to our patients and let them know exactly, you know, this is your IV alarm, and, you know, it sounds because, you know, if you bend your arm like this, you know, so maybe if you can keep your arm straight, sometimes you're going to not have this IV beeping at you, or don't take your SCDs off and they won't beep bad at you. Bed alarms, letting the patient know, and using effective communication so that they understand that this is an alarm, and if you stand up and we haven't turned it off, it is going to start beeping, and you will have people in your room. Just communicating in that way, I think this class will help us to, you know how to speak to our patients and in an understandable way for them, so that we all around can kind of like turn down the amount of alarms that we're having, just with, you know, making them knowledgeable as well about what the alarms that are on them are and what that means for them.
I guess there is one more thing I'd like to add, going right along with the communication. A lot of the things, I mean, alarm fatigue specifically, but a lot of these alarms are regulatory things, like not something simple you can change just on your floor by talking, you know, with your coworkers, like, oh, well, we should, you know, maybe we don't need these alarms, or maybe these are more appropriate, or whatever. But we've learned a lot in this class with types of communication and how to communicate with others well, and I think if we do take that extra effort to talk to our bosses, it will help make the situation prevalent to them, make them understand that's actually happening. A lot of times the people who have the power to make all these decisions on our floors are not necessarily on the floor because they're so busy with other tasks. So they don't really know what all is going on and where these safety risks are. And so it's good to talk to them and to let them know the severity of the issue, to bring it up more than once. Try and find ways to get policy changed, because that's a lot of what it is just regulation of when we need to have certain things, and it's just rules, you know, like with what Mallory was saying, you know, a lot of times they have patients on the bed alarm just because they scored either a number on a fall risk, or they have a higher number, so it seems like they should, I mean, according to that document, they need a bed alarm, but, you know, the nurse has the best assessment, and if, you know, if they seem to be completely independent, or if they have a visitor with them or something of that sort, you know, there are times when you can have that stuff shut off, but according to policy you're going to have to keep it on, and that's when you're trying to decipher, like, oh wait, does it need to be on now or not? I mean, can we ignore it at this point in time and then later it's active? You know, you don't really know. So it involves tons of communication, trying to problem solve and maneuver through this whole situation.
Okay. I think that is probably the end of the alarm fatigue presentation. Do you guys agree?
I agree.
Okay.
All right, I'm going to go ahead and push stop. Thank you.
Okay. Thank you.